I want to talk about what I've learned in 20 years as an overview with specifics on the Zeaxanthin vision function study, which was published more or less a year ago. The first slide is a very important slide because people think of macular degeneration as a slowly progressing disease, but it really isn't slowly progressing once you get into older age groups. And in fact, from the Regic study, persons aged greater than 85 years have a 10-fold higher prevalence of late AMD than those aged 70 to 74. So in the oldest this age group, we're likely to, which we're moving into, Western societies are moving into this group, these age groups, we're going to see many, many more people, and the changes are going to are rapid in this age group. And I've experienced this as working as an optometrist with World War II veterans who are 90 plus at this point. So this is a present problem. The other philosophical point is ARIDS-2 showed us that 66% of advanced AMD cases still convert. The most practical advice for the public, ODs, and MDs is to prevent AMD in the first place. Promote visual performance, individualize our care, and of course, educate patients. So I think that has to be our primary concern. So our research goals at our medical center, which is now a joint military Veterans Administration Center, is to create effective treatments with patient-focused care for 90% of the AMD patients with atrophic pathology. So I think it's consistent with the great work that's being done in Waterford, only on a much smaller scale. We want to help optometrists and ophthalmologists detect disease earlier with more targeted treatments. So we've been working on this for about 20 years. We actually had a hypothesis paper in '93 that was published that nutrition would be helpful for AMD. But we showed in 1996 that we could achieve stabilization of vision in the better functioning eye only. Then, based on Johanna Seddon's work from Harvard, in 1999, we did a very high-tech study with spinach, prescribing spinach to patients and looking at visual function, contrast sensitivity, which seemed funny at the time, glare recovery, and so forth. And we found effects just from spinach because that was the putative food at that time that was associated with decreased risk of neovascularization from Johanna Seddon's work. We then put that to the test with the lutein antioxidant supplementation trial in 2004 with 10 milligrams of Fluoroglow lutein, which I'll talk a little bit about. But Zeaxanthin, we next looked at Zeaxanthin at approximately the same dose as lutein, and that was published last year. So how did we get into this mess here? Well, we got into this mess because the diet in the US anyhow is increasingly homogenized to contain only 4 food groups, which is sugars, grains, vegetable oils, and dairy, which make up 71% of the energy in the US food supply. And as you can see, fruits and vegetables only make up about 8% of what the average American is intaking. And this is quite distinct from what Michelle Obama wants, which is basically 50% of our plate to be vegetables and fruit. So what we want and what reality is, the change is difficult, and the expression is culture will eat change for lunch, basically. And we're just not seeing enough plant food consumption. So that's very critical because whether you're talking about eye and brain health, disease is going to be 3 times more common with macular degeneration. Now, we haven't at all in this conference talked about these important things, that we have a lot of corn oil and trans fat and fried food and high carbohydrates in the diet. We really want to have more of this. We're going to see much better health if we have more of these foods. And this is pretty well established in the cardiovascular literature as well, which is, and cardiovascular disease is associated with this. So we have a good idea that we need weight maintenance and sunlight protection, especially at early ages before we have the natural protection from the lens, and we need plant food. Now, the NEI has looked at 4 nutrients, 5 maybe, vitamin E, carotenoids, and not all the carotenoids, not astaxanthin, for instance, vitamin C, zinc, and omega-3 fats. So we haven't looked at the associated bioflavonoids with vitamin C. We haven't looked at magnesium at all, which is the third most deficient nutrient in the U.S. diet. We haven't looked at selenium, which recharges our glutathione peroxidase, glutathione reductase, to give us enough cellular energy, cellular health in terms of glutathione. We haven't looked at sulfur, talked anything about sulfur compounds. Omega-3, vitamin D, we haven't talked about vitamin D, extremely important. It's the body's major steroid, in fact, and it regulates 10% of the US genome. And we haven't talked about all the isomers of vitamin E. We know that builds up parafoveally, and the tocotrienols are very important. And I think what's really missing from the conversation is what's found in fruits and vegetables, which is the B vitamins. Now, there has to be a reason why, if you went to poster 1, you saw that 2% of the Indian population has AMD by their measurements over 3,500 patient study, and only 2 people had Alzheimer's disease, and only 2% of that entire group had AMD. And those numbers are far larger in both Ireland and in the United States, far larger, perhaps 3 or 4 times higher. So we have other issues. We have chronic aspirin use and excess smoking and excess sugars, which all deplete vitamin C. And we have environmental issues in the US, excess copper. From 80% of our plumbing is copper. And we have a lot of meat consumption past age 50. And we have a lot of this excess fried foods and vegetable oils. We have drugs that deplete nutrients such as acid blockers, PPIs. And we have stress in the US culture. We have hormonal changes. So if you ask what my future direction would be to address some of these other issues and not merely focus on these 4 groups. So I have 2 slides on what I've been working on in the last 2 years. I've been working on a red wine extract. And I like this product because it regulates a whole series of processes in the body. It decreases inflammation, and it decreases epoxy-inducible factor and VEGF genes, upregulates endogenous antioxidants, works on blood clotting and vasodilation, works against the excess iron and copper in the environment, decreases oxidation and cell adhesion, and so forth, decreases calcification. Now, this has been published in a CRC, Johns Hopkins text, and there's a follow-up article about this with 4 other cases. But it shows you the power of nutrition. This is a baseline patient, 88 years old, the OCT, and showing you over time the improvement in visual acuity. I have several slides on this. I only put in 2 slides on this. But what we're seeing is de-aging of the retina and a flatter, more youthful retinal architecture. So we sometimes see that. And the reason I threw this particular slide in, anyone interested, I can show you the macular pigment distribution on this. We had 35% more macular pigment with no carotenoids in the formulation. So there's no carotenoids, and yet we had apparent improvement in cellular health and higher macular pigmentation. So getting back to the focus of this, which is zeaxanthin, we wanted to evaluate zeaxanthin at about the same dose. And this is, zeaxanthin is 18% in foveal. We really haven't talked a lot about zeaxanthin in this meeting. With 3 intervention groups, we had a lutein group, a zeaxanthin group, and we had a combined group of about 17 milligrams between the 2. We had excellent pill compliance. We examined people with analysis of variance similar to the last study. We looked at them at baseline 4 months, 8 months, and 12 months. And we looked at our 4 groups who had a FAUX placebo, so this was not a real placebo, zeaxanthin, and we had zeaxanthin plus lutein. So we had N equals 60 patients were about 75 years of age. They were light smokers. They were all pretty close to obesity. They had diabetes. About 12 patients had diabetes. They had AMD for about 3 years. Some alcohol consumption. They had relatively low skin carotenoid scores. We did not do serum carotenoids, but we used the Pharmanex. And they had notably very, very low retinopathy. So this was an ARIDS report number 18 equivalent score, which, as you know, goes from 1 to 4. So they had about a 1.33. So it was very low. There were very little differences between the group, except the zeaxanthin group had notably a little bit worse retinopathy. to start off with, the zeaxanthin group. Baseline visual parameters were fairly similar between the groups. There was a greater degree of scotomas. So we measured some novel things here. The visual function questionnaire from NEI, distance visual acuity. We looked at low and high contrast visual acuity. We looked at the skill target, which is also a measure of contrast, the photopic distance contrast sensitivity, glare recovery, shape discrimination, which is a novel test that I want to introduce the group to, and color vision, parafoveal color vision, looking at blue cones, and kinetic fields, and estimated macular pigmentation. So the first thing we found, I think as Dr. Bernstein found in his published report from his group of, I think, 100 patients from the Moran Center, is that the carotenoid scores in the skin did not match the macular pigmentation. But we saw improvements in the carotenoid scores in patients who were supplemented by 12 months. This was statistically significant. Now, when we looked at 1 degree estimated macular pigment, we used the MPS-1, which is similar to the one that's out in the display area. We saw that we had low normal macular pigment in all 3 groups, which went to normal macular pigment by the end of the study, but there were no differences between the 3 groups. We used other statistics. This is just another way of looking at the data, looking at baseline to 12 months with zeaxanthin or the combination. And this was almost statistically significant here, but you see there was a little difference between the groups. So our conclusion is that we saw increased foveal visual function with zeaxanthin. We'll show you that. Over time, so we have baseline, right eye, left eye, 12 months, right eye, left eye, and we can see we're using a scale from we converted our acuity scale to 0 to 100, basically. So 100 is going to be perfect, 20/20 that is, 105 would be 20/15, for instance. And so from baseline to final, we see that in both right and left eye, zeaxanthin trended superiorly. This was the same when we used near targets. So there was an effect with lutein, but it was much stronger for zeaxanthin. And the combination was less than zeaxanthin alone. This is the target we use. This is, uses kernel mathematics to slightly change the target. This circle is, everyone can most likely see that this circle is different than the other 3, and this circle is different. So this is a replicate. So we do it twice, and it gets more difficult as you go down. So this target was developed by a retinal specialist, Dr. Wang, at the Retinal Foundation for the Southwest. It's a 1 degree target, and it's a measure of photoreceptor alignment. And I think it's much more germane to early macular degeneration than an amsler-grid. An amsler-grid is notoriously insensitive to early and moderate macular degeneration. So we use this, and it's a validated technique. Several papers have been written on this using this test target. It's now available as an iPhone app through a secondary company. Now, when we use this target, we found that zeaxanthin was superior at 12 months, almost trended 0.06, which makes biological sense for where zeaxanthin is building up in the fovea. So what I want to show you here is that 8 milligrams zeaxanthin alone raised the central 1 degree estimated macular pigment, filled in the central dip, and eliminated scotomas in the ZVF study. So we did 1 wavelength autofluorescence of macular pigment measurement. Unfortunately, so many of our patients had cataracts in the study that we were only able to use this technique on about 15% of the sample. Well, this is a 50-year-old patient. So what we're seeing is traditional macular pigment here going up from 0.34 to 0.48. This is patient number 50 in the study. And we can see we have a double hump here. This is a patient who for many, many years even though they have 20/20 vision, was unable to see, always complained about their vision, and you can see the central peak is filling in here. over time, and with an increase in macular pigment. And I'll show you, this is how the whole group looks for the scotoma data. Now, for the scotoma data, we used a touchscreen device, and again, a novel device from Rush Ophthalmics in Oregon, and we were able to measure scotomas dynamically on a computer screen, and the patient was able to trace with their finger if they saw a scotoma and where the scotoma was. Well, zeaxanthin proved to be, and we used 5 different contrast targets, and zeaxanthin proved to be the most effective. But there were no differences over time, but from baseline to 12 months. This is an example of using this touchscreen device, and you can see over time that the center is opening up with this patient. So we have a completely dense center, and over time it's opening up. And that correlated with, in the left eyes anyhow, with better shape discrimination. So we had 2 measures. Now here are other patients from our study, Z58, Z55, Z32, and Z13, and we see over time that the center scotoma is either diminishing in size or being eliminated entirely in the patients on zeaxanthin. But again, this is not 2 milligrams of zeaxanthin, this is 8 milligrams of zeaxanthin. So zeaxanthin in a formulation means better visual acuity, better foveal shape discrimination, and possibly better protection against occult foveal membrane since it builds up in the center. There was an ARVO poster presented 2 years on that, and there's a paper pending on that in that issue in review. Now moving on to lutein, we feel that combined with the results of the LAST study, and the LISA study was presented this morning, the results were identical to what we published in 2004. So that was consistent to what we've seen before. Better parafoveal function. We had better contrast sensitivity, better glare recovery with lutein. We used the stereooptical device, and we did area under the curve of the contrast sensitivity function, and we see that lutein, it was statistically significant, but zeaxanthin, there was only a trend. And this was not significant for some reason when both were put together. You can see this was less than 0.10, not even a trend. When we did this test at NEAR, we got the same result. We used a column brander, 10% low contrast card. It's a relatively inexpensive card. And we found that lutein showed an improvement at p equal 0.04, and zeaxanthin was not significant. This is the COA Optimed AS14B glare recovery tester. Presents a 30-second bleach to the eye, each eye, and then there's a Landolt C ring within it, and the patient has to identify the correct orientation. So we have seconds on the y-axis, and we have baseline 4 months, 8 months, 12 months, right eye, left eye data, and we have lutein in yellow and zeaxanthin, and you can see that there was a trend down. Glare recovery was improved in all 3 groups. But again, there was no difference between the groups. The Chroma Test is a novel test that was actually developed here in the UK, and it measures large field blue cone thresholds. So there are a few blue cones in the parafovea, and this will pick up the integrity of the parafoveal visual function. So it's very similar to contrast sensitivity. And again, we showed that there was an improvement with lutein, at least in the left eyes of our sample over time. This is from our LAST study in 2004, and basically is showing that there was an improvement in scotoma count over time at 12 months. And we looked at lutein again. Again, we didn't have that many patients with lutein in the ZVF study. But again, we see a similar type of phenomenon where we see improvement in the center field. And we don't know whether that is as a result of, we have a little bit of a defect here missing, conversion to mesozeaxanthin over time from lutein. So it's a suggestion that higher dose zeaxanthin benefits AMD pathophysiology. So this next slide, we had our fundus images evaluated using ARIDS report number 18 by a retinal specialist within our practice. And the only thing that's curious here is that it's not significant, but it started with the worst pathology, but only group to improve was the Zeaxanthin group as far as the pathology. And when we separately evaluated the lipofusin, and we showed basically that in left eye, Zeaxanthin improved, while in the lutein group, it deteriorated, and this was significant by a statistical test called the Sheff test. So we have two suggestions that Zeaxanthin may be better for the pathophysiology of the disease. So an possible alternative to the Waterford central dip hypothesis is that humans don't require the poorly absorbed third retinal pigment yet to be found, and I have to change this statement because it is found in the skin of fish. We don't need MZ to fix the central foveal dip believed to be associated with MD. Why does the retina convert L to MZ only in the retina? Perhaps the retina really utilizes Z and settles for MZ, and MZ might inhibit enzymatic transformations important to the eye and brain health. So I think this is an area that needs to be addressed. There needs to be studies of MZ versus Z, head-to-head trials, and not just the 2 milligrams that was used in the ARIDS 2 trial. Now, moving on, we have also looked at general health using the NEI VFQ-25 evaluation. And what we found is that there was a weak correlation with macular pigment and overall health, which you might expect. There was a weak correlation of the VFQ-25 subscores with driving. So that really stands out. Okay, driving ability was affected, and that I think that makes sense after attending this conference that the basic skills to see in terms of visual pre-visual processing are just as important as the cognitive deficits that one has in driving. So it's very well explained. Now, driving and macular repigmentation. We're able to look at the macular pigment at baseline versus the driving at 12 months, and we see that there was a trend there. This is a linear regression model. By 12 months, we were able to see that we had increased pigmentation, and we had a statistically significant increase in self-perceived driving ability by the end of the study. And we published that in this journal, showing that there was enhanced driving vision in elderly adult males with macular degeneration. And this has recently been repeated in a Chinese study. I don't have the reference to it, but it was just published within the last 3 or 4 months. A study from China found exactly the same thing, that when we increase the macular pigments, elements of driving vision improve. So that's certainly important. So what are the lessons that I've learned? In the Zeaxanthin study, we found that Zeaxanthin in higher doses improved macular pigment in early AMD patients, similar to lutein. Zeaxanthin has unique visual properties beyond lutein, such as improved foveal parameters, such as foveal shape discrimination, improved scotoma count, kinetic visual fields, a weaker but trend toward significance with contrast sensitivity and glare recovery and chroma thresholds where lutein is superior. Higher dose 1-to-1 ratio of Zeaxanthin to lutein increases macular pigment density, but not as well as the individual components. So there's possibly some competition going on. So I think when you think through further studies in this area, not only use a 1-to-1 ratio, but use different ratios in the next set of experiments. We need to be using different ratios of Z and MZ, for instance. So I wouldn't do Z to M. I would look at Z to MZ, but I'd also look at different combinations. MP density is related to subscale driving performance. Zeaxanthin benefited early AMD driving ability. So what about the future? What do we learn about the future? Well, we should be talking to sons, daughters, sisters, and brothers when we examine them. In ophthalmology in 2013, the typical approach, there are exceptions, is that there's typically little to no discussion about diet, supplements, and exercise for the worried well, patient with a family history of eye disease, AMD, or diabetes. We're relying on big level 1 ARID science to rescue end-stage patients. We're ignoring other science with expensive and using expensive and invasive injections. We're still using Snellen acuity from 1862 and Amsler-grids from 1895, and obsolete fundus cameras to evaluate mild and moderate disease, which are almost worthless. So I think that's come out by other speakers during the meeting. Optometrists can be the first to alert the patient to early symptoms and signs of atrophic AMD. The symptoms would include a drop in contrast, more light to see, for instance, reading a newspaper, or however people aren't reading newspapers as much as they used to be. A decrease in glare recovery, being blinded by headlights. The signs could be decrease in contrast sensitivity, and also a decrease in rod dark adaptation, which can take minutes, or glare cone recovery, which can take seconds. We can look at structural imaging of autofluorescence, parafoveal thinning of the OCT, melanin migration, and choriocapillaris thinning. So I think that actually the instrumentation is going to drive this. We need to be more proactive in terms of the significance of focal versus diffuse melanin disturbance and lipofuscin when it's seen in the posterior segment. As an early indicator of retinal disease, including AMD, we can significantly treat the visual disability with little or no risk. So we want to start talking about detecting early disease. I'm encouraging all my students and residents to buy cameras with autofluorescence because we can pick up early disease. And we've published, this was published in Nutrients last year. These are 4 eyes, all having 20/20 vision, but the disease progresses in a horseshoe fashion. So if we're using Snellen acuity, we're going to totally miss this. But if we're doing OCT and doing image simulation, we see that there are very big differences. Image processing on the same patients. We can use multispectral imaging to look at melanin migration, as shown here. And this is the new boy on the block. This is a 6.5-minute AMD vision test. It's FDA pending. 510 cleared as a dark adaptometer. And again, looks at the earliest point where AMD develops, which is north of the fovea or superior. And this is likely to be approved. Many prestigious institutions have contributed to the research of this instrument. And this is quietly happening in the background, but we're going to have a 6.5-minute AMD vision test coming along based on dark adaptation, normal, early, intermediate, and advanced AMD. Dark adaptation is certainly a much better measure of what's going on in the retina than visual acuity. So I'd like to thank Kemin, Chrysanthus, who supplied the Zeaxanthin, as well as many other sponsors for supplying equipment to our lab. And I would like to encourage people to join the Ocular Nutrition Society as well, and there's going to be international chapters opening up in different countries. So if you're interested in that, you can see me after the conference and I can give you further information. Thank you very much.
Thank you very much. Questions?
Hi. You used several contrast sensitivity tests. I was just wondering if there is one that you preferred best.
I use the one that's used by most pharmaceutical companies, which is the stereooptical contrast sensitivity system. It also has a glare, 2 levels of glare on it. Yeah. So you can do mesopic, you can do photopic contrast sensitivity, and you can add in glare. And it has image simulation software with it. So that's the one I've used because that's one of the best validated measures of contrast sensitivity.
And you feel like that suffices enough? Yeah,
I think it's good. As I mentioned, contrast sensitivity is reduced in so many disorders: glaucoma, cataract, macular degeneration, neurodegenerative disease, Alzheimer's, Parkinson's. So it's not a very, very good measure of what's happening in AMD. It's a good measure of the visual loss in AMD, but not the pathophysiology so much. So I think the dark adaptation test is going to be the better test to use in most clinical trials.
And as a second question, I don't know if when you measured macular pigment using the MPS-1, did you use a reference point for that?
No, we used it's an estimate. It's similar to the one that is out on the floor now.
I was just thinking because a lot of your patients were a lot older, and if they have
Yeah.
cataracts, that might affect it.
Right.
So did you somehow control for lens opacity?
No.
No. Okay.
Not measuring at the reference, for me, is a massive concern, and therefore I would question the data based on that. I mean,
Yeah.
it's just part of the test. It's something you have to do, and I know there's you use formulas and large databases to try and predict it, but I think Randy might comment better than me on this. But everyone has a different number out there, and I don't think we can be guessing. You know, it's like only doing half the test as far as I'm concerned. So, based on that, I'd have to question the macular pigment response at least.
Well, you know, I mean, sure. I think especially with cataracts, you know, the cataracts are, you always think of cataracts as optically dense, but sometimes the center of the cataract can collapse and make them almost optically transparent. So the range is huge. But, you know, I think that's a criticism that you could level at many macular pigment techniques that use average values in the modeling to derive the number. Because almost all these things vary in enormous ways and make the value for an individual very questionable.
Any further comments? So thank you once again.